Can you all hear me? Great. All right, yes, I realize I'm the thing that stands between you and cocktails. So sorry for that. I was a bit disappointed that I was going to be the last one. We're waiting all day for my chance, and you'll be like, is this over yet? But I thought actually maybe it's a great thing, because you'll, when you think about what did I learn today, sterile compounding or compounding will be the most recent thing in your mind. So yeah, as was mentioned, I am a pharmacist, and sometimes I like to tell myself that I'm different than other pharmacists. I'm more relaxed, I'm funnier. But when I really think about it, I'm a lot like every other pharmacist and pharmacy technician. I like to have clear expectations in my work and in life. I'm fairly risk averse. I like to be prepared. I have notes for today. And in the last year, I was given an opportunity to take on a quality lead position, which is a new position with Lower Mainland Pharmacy Services. So we are the health authority pharmacy provider for the Lower Mainland. So I took the job, and my boss said to me, Tamar, the thing that I want you to work on first for quality is sterile compounding. I was like, oh, okay, sort of have some memories of sterile compounding. And she said, the reason why is this is one of the riskiest things we do, and it keeps me up at night. So great, I take this job, and I think like, okay, so I got to learn some stuff about sterile compounding. Like I can see it happening over there in the IV room, and I remember that CSHP video I watched in 4th year. And I realized as I started to delve into it and started learning that compounding and sterile compounding, I had a huge gap in knowledge. I wasn't aware of the risks there. I wasn't really aware of best practice, current practice, what it should be. And as I look back, I had done a lot of risky things over the years in my career. Early on, I remember as a resident, I think I rewatched the CSHP video, and then I made chemotherapy for real patients in the hospital, which is pretty scary when you think about it. But not so long ago, I was a dispensary supervisor, and I clearly remember a bunch of decisions or advice I gave or made about IV compounding or what to do for repackaging of an IV product because of a drug shortage. And the advice I gave with the knowledge I have now was very dangerous, and it's only, I'm very lucky that no adverse effects or even more serious consequences ensued. So I think as a profession, if we go, oh yeah, I have the clicker, there we go. So we're talking about compounding today. Here's a picture going back to the future. I think Bob and I didn't plan this, but it's a really great tie-in. Compounding used to be our thing. That's where we started. And as modernization happened, big pharmaceutical companies, we started to do clinical work. We really expanded our practice, but we kind of forgot about this fundamental piece of our work, about compounding, about how to do it right. And I think it's as we'll talk about a bit more, it's become a bit of a collective blind spot. We've sort of handed down this mythical knowledge about how to do it. Someone trained someone else, but we're not really, might be different depending on who trained you. Yeah, it's a collective, it's a knowledge gap, but it's also a really big risk. And we'll talk a bit more about some of the things that have happened which have led us to today, for why suddenly this is a big push for our profession to bring up our practice and to make sure that we're delivering a quality, safe product to patients. So I'd like to invite you to come along with me to go back to the future in compounding. And I think we should sort of step into it with equal parts curiosity and sort of fear and trembling, knowing how we can impact patients for good or for worse in this area. So I have nothing to disclose. No one is paying me for this talk, and I don't think you're allowed, but I didn't see anything in there about no tips. We're at a hotel, tip me for this talk. So learning objectives, we're going to talk a little bit about what compounding is, to look at the regulatory framework for compounding in BC and in Canada, and to just look at some highlights of what the guidelines that are coming out around compounding, what types of things they want us to look at and track. So the goal today is not to make you experts, but to whet your appetite to learn more. So what is compounding? NAPRA, which is the National Association of Pharmacy Regulatory Authorities. So Bob is on that, part of that organization. We are as the college. And so the definition that NAPRA uses is the act of preparing something, in this case a pharmaceutical preparation, through preliminary work to put it in a usable state. So a little bit somewhat helpful. Health Canada has another definition where they say the combining or mixing of two or more ingredients, at least one of which is a drug or a pharmacologically active component, to create a final product in an appropriate form for dosing. So we're taking a bunch of ingredients, at least one of which is a drug, and we're making a product that's usable for a patient. So we're taking it in one form, we're doing something to it, and giving it to a patient. So just to distinguish this a little bit, or give you sort of a picture, if we think about baking a cake. So, just to kind of add a little bit, sorry, what it's not is, what it doesn't include is mixing, reconstituting, or other manipulations that are kind of on the label. Like if it says, take this many mils of water, add it, shake it up, Health Canada says that is not compounding, unless that manipulation specifically needs to be sterile. So it's a little bit confusing there. So if we think about baking a cake, what they're saying is, if you are making a cake from a mix, you're just adding some water, that is not compounding. If you're baking a cake from scratch, that is compounding. We'll get into a little more nuances there, unless you're baking a cake mix and it needs to be a sterile cake. So I don't know if that's helpful or not. So we have cake mixes, we have baking a cake from scratch, and then you kind of get into the scenario, well, what if I open a bakery and I want to make a whole bunch of cakes? So that gets into manufacturing. So let's talk a little bit about the difference between compounding and manufacturing. So compounding in the practice of pharmacy is regulated by the provinces and territories. So for us, the College of Pharmacy of BC regulates compounding, whereas manufacturing is regulated by federal authorities, so Health Canada. Compounding, by definition, occurs in the context of a patient-healthcare professional relationship. So if I'm baking a cake for Bob or George or Shifa, that is compounding. And I can do that just in time, or I can do a little bit of prediction. I can say, well, I know I've got these birthdays coming up in the next few weeks, so it's for a specific person, but I can do a little bit of planning ahead. That's okay. If we get into producing compounds independent of a specific patient healthcare professional relationship, then that's manufacturing. So, great. Compounding, we can't use compounding to get around legislation. For example, the Food and Drugs Act or the National Drug Schedule. So we can't try and copy something and get around intellectual property rules. We can't advertise our compounds. So the same rules that apply, that we can't try to get around regulations. For manufacturing, so what they do is they say, okay, we're not going to give you really specific rules. We're not going to come and look at every one of your compounds, but you still have to abide by the rules that are out there. For manufacturing, Health Canada says, actually, you have to abide by all these rules, but we're going to actually sit down and review all your information. We're going to go through health, safety, efficacy, and then we'll give you a notice of compliance or a DIN to verify that's happening because you're making this on such a big scale. And finally, compounding doesn't duplicate something that's commercially available. So it's a custom therapeutic solution. It's something we can't find quite the right thing to meet this patient's needs that is commercially available. But in manufacturing, it's being produced at a large scale, so you have to be sort of have an establishment license, follow extra guidelines, because you are the one producing the commercial product. So hopefully that gives you some idea of the difference between just reconstituting something, compounding, and then manufacturing. And there's the reference here, there's a document, a Health Canada document that kind of teases this out a little bit. And I found it quite helpful, and what they say is if you're not sure, ask. Ask your provincial regulatory authority or ask the federal regulatory authority. So good advice. All right, a question for you. Knowing the definition of compounding, does compounding occur in the pharmacy in which you work? So your hospital, community, whatever you're attached to, even if you don't do it, do you do compounding? So 94%. Probably all the college people are the other 6% don't do any compounding. So this is applicable, whether you're directly involved or not. You might even be involved in little parts, occasionally being asked to check something or to prepare it. So why are we here today? We're here because there's some regulations coming out around this, some attention being put on the issue of compounding. So why is this happening now? Why is the spotlight suddenly on compounding? It's because bad things have been happening, and we're not doing a very good job of sort of policing ourselves. There's been some effort to try and track some of the issues around contamination or improperly compounded products, but we know there's a very high degree of underreporting. Some big incidents that you may have heard about in the last few years. One that happened in the United States was a pharmacy in Massachusetts that was making, amongst other things, methylprednisolone bags and shipping them across the states. And they were knowingly cutting corners and not following a good process. And about 1,000 people got fungal meningitis, and about 64 people died. So a bunch of the staff from this pharmacy actually have been charged and convicted of a whole slew of charges, including murder. So very serious. There's another one here, sorry. In more closer to home in Canada, you may recall a couple years ago the chemotherapy underdosing incident. So that was a pharmacy that served hospitals in Ontario and in the Maritimes. And they were, there was a miscommunication about what was on the label as far as content in the bag versus concentration. So the producer was understanding it one way, and the pharmacy, or the hospitals on the other end, were understanding it a different way. So it took over a year to discover, and a pharmacy technician identified the problem. And about 1,200 patients in that time had received less than the prescribed dose of chemotherapy, potentially affecting their outcomes for their conditions. So because of some big incidents like that, and looking closer and seeing that the regulatory authorities in the States and in Canada, whose job it is to protect the public, suddenly there's a big outcry and attention given to this, and people saying, what are you guys doing to make sure that compounding happening at community pharmacies and hospitals across North America, what are you doing to ensure this is safe? And we realized, Bob realized, that we hadn't really looked at this in a long time. And in some ways, it was a bit of a free-for-all. There's information out there, there was guidelines, but not really consistent push for pharmacies to practice in this way. So a lot has been written recently, a lot of reflection, pulling together of data on this, and really an indication, as you can see at the bottom, ISMP, talking about some of these tragedies being a symptom of a system that is very broken. And what the Institute for Safe Medication Practices has said is, unfortunately, There are too many in healthcare that feel if it hasn't happened to them, the adverse experiences of others do not apply. So things have happened, and even in spite of some of these big errors, many of us still haven't changed our practice. So there's really a call to action to say, okay, we can't continue to practice this way. We need to take a look at the best evidence and apply it. So another leader in sterile compounding, Eric Costango, has said, business as usual is no longer acceptable. We must embrace standards and guidelines that incorporate evidence-based science and best practice vetted through public comment and review processes. So here we are, knowing that something needs to be done, and the college is stepping in to say, to give us guidance around this issue. So currently, the College of Pharmacy of BC, compounding is addressed in Professional Practice Policy 64, where they reference standards that NAPA put together in 2006. So they're very general. There's some guiding principles around compounding, but not a lot of detail. So a couple years ago, NAPA sat down and knew it needed to update and put more detail in these guidelines. And these standards that are going to be coming out are the minimum requirements. So you can always do better, but they sort of set the minimum standard for compounding. So the goal is, there will be 3 sets of compounding guidelines that NAPA is going to be put out. The first set on the top are guidelines for non-hazardous sterile preparations. So I got the date wrong. Those guidelines were actually published in December of 2015. There was some consultation that the college has done in May, and there'll be some decisions from the board in November around the timing of when these guidelines will be enforced and implemented in BC. So that is non-hazardous sterile preparations. There'll also be guidelines for hazardous sterile preparations coming out likely in the fall. It was supposed to be around now, but we haven't seen them yet. And then finally, there'll be guidelines on non-sterile compounding, and those are projected to come out next year. So you can see I've kind of put some other acronyms around those guidelines. So these guidelines, they didn't just make them up from scratch. There's a lot of other organizations that have guidelines or have information that are feeding into these. So one being USP, the United States Pharmacopoeia, and some of you may have heard of those guidelines. So the NAPA guidelines draw heavily on the US guidelines. So the sterile preparation guidelines that have just come out sort of parallel USP 797. The non-sterile preparation guidelines will be similar to USP 795. And then there's a little bit of a USP 800 looks at hazardous compounding, but we've kind of pulled it out slightly differently than the US has. Yeah, so I won't get into too much more detail there, but it's informed by a lot of other information. So occupational health and safety for us, WorkSafe BC, will kind of add some things or influence the way that we apply. Health Canada is part of an international organization called PICS, so that was some of those guidelines were also drawn in. So just to give a little bit more definition on, for each of these guidelines, what types of compounds are they addressing? So for non-sterile compounds, this is probably pretty intuitive. Most of you have some experience with compounding these types of things. So non-sterile oral liquids, creams, ointments, suppositories, tablets, so things that are not intending to be sterile. Sterile compounds, so the first thing we often think of is injectables, whatever route that they're being given by, but it also includes things like eye drops, ear drops that are for intratympanic administration, irrigation solutions for body cavities, anything that needs to be sterile and is going to be connecting with body spaces where sterility is important. And finally, hazardous drugs. So in community pharmacy, I'm not sure if we have thought a lot about the distinction between drugs that are hazardous or not, other than sort of chemo-type drugs. But the guidelines that are distinguish what you need to do with compounding involving hazardous drugs and compounding that does not involve hazardous drugs. So knowing what that means is important. So there's an organization called NIOSH, which is the National Institute for Occupational Safety and Health. And they have some criteria, which are listed here. Carcinogenicity, teratogeny, reproductive toxicity, organ toxicity, genotoxicity, and having a drug profile that mimics something we know is hazardous. So they take a look at all the drugs that have come out and they sort of rank them. How potentially hazardous do we think this is? How much evidence is there for hazardous effects of this drug? And so they make a list, they rank them, and then they say you should use this list to kind of inform how you handle drugs. So in the compounding guidelines, when they give instructions for what to do, they draw out hazardous drugs so that we prepare them in a safe way, protecting both patients and ourselves. So knowing about what sterile compounds are, what non-sterile compounds are, and hazardous drugs. Another poll here, I didn't put every permutation, but what kind of compounding does your pharmacy do? Do you handle both sterile and non-sterile? Do you compound hazardous medications? So it looks like most people are involved in some way, or their work site is in non-sterile compounding. And definitely some hazardous compounding as well. So we're quite a lot of representation across the spectrum there. So this will be important as we look at the types of facilities and protection we need for compounding. All right, so knowing a bit of the background, what's compounding, who regulates it, what are the sort of categories that it falls into. We're just going to touch a little bit on what do the standards say about this compounding. So right now we only have the final copy of the non-hazardous sterile preparations, but the drafts of the other two guidelines are out. For non-sterile preparations, it's out for consultation in some ways. I think not too widely. If you're a member of CSHP, it's already out for consultation. So the standards, the general, but they're all sort of built the same. And really what they look at is making sure you have a process for compounding, a robust process that's replicable, that happens in the same way every time, and that you have proof that you have this process and that you're following it. So it's process and proof. And the goal is to build quality into your compounding work so that we're not just spot checking at the end, because then we know we might miss things, but we want to build a system that consistently delivers a quality product. There's been some, and to know that it's not, meeting the standards is not sort of a one-time, run to the end, ding the bell, you're done, but it's a continual state. We have to be continually monitoring and ensuring that that quality is there. So one part of all the guidelines for all the categories of compounds is that we have in-house knowledge and expertise. So we need to know what we're doing, and we need to have designated people at our sites that are taking responsibility for this work. So the pharmacy manager or department head, according to the guidelines, is ultimately responsible for what happens at that site, whether you're directly involved or not. You can delegate some of that work to a pharmacist or a pharmacy technician who can be your compounding supervisor. It doesn't have to be an official title, but that work has been officially delegated to them. And you need to have qualified staff, so they need to know what to do, and they need to be fully complying with that, those processes and procedures. So some of the things that are required is that you have an established educational program. It has to have a theoretical component, so written or study, and also a practical component. so hands-on observation of what they're doing. There's some objective testing, so gloved fingertip testing where they put their sterile gloves on, dip it in a Petri dish, and see if they grow any bacteria, just if we know if they're garbing correctly. Media fills, which is, this is for sterile compounding, sort of making a fake product, and then we let it sit for a while and see if it grows anything. So again, we have processes, we have an established educational program, but then we also do some testing. We have proof that our people know this stuff and we're doing it correctly. And you don't necessarily need to come up with that stuff on your own, the educational program. There's the guidelines that you can use just straight up. There's some commercial organizations that are more and more developing programs that you can purchase. CSHP has a program that they have developed in Ontario, and there's some preliminary work to see if we can bring that to BC or fan it out across Canada. Yeah, so first, have the knowledge on site. Secondly, all the different guidelines require that you have comprehensive policies and procedures. So you have written documents that describe all of the compounding activities that happen at your site. So there's sample templates in the guidelines. You can also develop your own. It includes stuff like what personal protective equipment does staff need when they're doing this activity? What cleaning do you need to do? What products and supplies are involved? How are you verifying your final product? So the policies and procedures need to be in a standard format, and they need to be reviewed regularly. So it looks like in the guidelines about every 3 years at minimum, but also as recommendations change, your on-site policies and procedures should follow along with that. So again, a process and then proof in written format that can be reviewed and replicated. All the guidelines require that you have appropriate facilities and equipment. So what that equipment is depends on what you're making and how risky it is. So the more times you have to manipulate something, starting from non-sterile ingredients, if your goal is to have a sterile product, all of that increases complexity and risk. So the first thing you need to do is have a good idea of what you're doing. And there's some risk assessment methods in all of the guidelines for you to identify how risky or complex what you're doing is. So the requirements depend on how complex and risky, whether you're compounding hazardous products. So that will mean you'll need additional protective equipment for your staff or additional facilities, and also on workflow. So the place that you're doing this work needs to be appropriate for the amount of work you're doing, the number of staff that are working in that area. So the specifications are laid out in all of the guidelines. It includes the space you need, generally how it's laid out, although you'll always customize that for your site. The fixtures or finishings that you need, so easily cleanable surfaces, and then also engineering control. So that means things like laminar flow hoods or biological safety cabinets sometimes, or negative pressure rooms if you're dealing with hazardous drugs of a certain nature. So again, like our other requirements, there's a process. There's requirements laid out. There's requirements laid out for how you certify that equipment to ensure it's functioning properly. You'll be required to do some environmental sampling. So for sterile environments, testing to see if you're doing your cleaning processes correctly. Logging things like temperature or pressure in the room on a daily basis so that you can monitor somewhat in real time of how your environment is performing. Again, so we're not just jumping to the end product, but we're looking at everything that's going into making that product, making sure it's performing the way we want it to and consistently so that we have a safe product at the end. The guidelines will require documentation for sort of every step in the process. And a big part of that is a master formulation or compounding record. So for everything you make, you need to be able to show the steps you took to do that and also what went into that product. So lot numbers, expiry dates, who made it, all that kind of thing. Temperature and pressure logs that I mentioned for some of your equipment or facilities. Maintenance records, staff competency assessment records, incidents, accidents, recall logs. So everything we do, again, we should be able to go back and trace what happened. And I think this is a real opportunity for innovation, because a lot of this could be really labor intensive. So I think it's, as we all have to comply with these guidelines, it would be great to have some labor saving or innovative ways to handle this information. Another big piece of the guidelines for both non-sterile and sterile compounding is beyond use dating. So this is how long you can use the product or that it's usable after you've made it. And this looks at not just stability, so how long the drug is stable for before it starts to break down, but how long could we reasonably use that product before microbial contamination is more likely. So it's based on the type of formulation. So this is looking at non-sterile preparations, whether it contains water or not. We always want to be conservative in our beyond use states and use evidence where we can. So if you don't have, again, the non-sterile guidelines are not finalized, but this is currently what's in there. So if you have a non-water containing formulation, the maximum beyond use date is 6 months, unless one of your ingredients expires earlier. For oral water containing formulations, the maximum beyond use date is 14 days, and for water containing formulations that are not oral, so like topical or other things, it's 30 days. For sterile preparations, again, what beyond use dating you can do is based on the complexity of the preparation and how risky the process is in making it. And it's also impacted by what facilities or engineering controls you have at your site. So if you, for sterile compounding specifically here, if you don't have a hood or a HEPA-filtered pressurized room at your site, any sterile product you make is for immediate use only. If you only have a laminar flow hood or a biological safety cabinet, by the current guidelines that are out, the beyond use date is 12 hours or less for your product. That potentially may change a little bit. The US guidelines are being revised, and there's some talk of that going up to potentially 24 hours, but that remains to be seen. If you have all the facilities and equipment that are possible, so a laminar flow hood and a properly engineered room, you can see, depending on what you're making, and there's risk assessment in the guidelines, you have anywhere from 24 hours up to 14 days for most products, unless you're freezing it. So this will definitely impact some of the ways we do our work, or how often we're making products, or what we may be able to provide our patients from our sites versus having to look for other sites or other ways of meeting their needs. So one more question. Knowing a little bit now about what the NAPA standards contain, does the pharmacy you work at follow what's the NAPA guidelines for beyond use dating for non-sterile and for sterile compounding? Are you roughly within those beyond use dates? Yes. So it looks like a lot of sort of 2/3, 1/3. And I think for sterile compounding, it's probably one area we have a fair amount of work to do. So we'll just speed through the end here. A few more things that all the guidelines contain is they talk about having robust procedures for packaging, handling, and tracking products, including waste management, so for hazardous drugs or sharps, and a rigorous quality assurance program. So everything that you do, as I said, it's documented, and you're tracking it on a regular basis to identify any slips or any gaps in your processes and procedures. So finally, just to talk about some resources, and I think when you start looking at the guidelines, it might be a bit of an eye-opener to see how extensive they are and what's all required. But I would say you just need to get started, and it will be a process. It can be fairly labor-intensive to get prepared, and the way we do things going forward will probably be more time-consuming and potentially more expensive as we go forward. But there's some resources I have to suggest maybe to help you get started. And I have a help button here, not the easy button. So yeah, but it is for the best for patient safety. So one is reading the NAPA model standard. So as I said, the first non-sterile or the first non-hazardous sterile guidelines are out, and the other two will be coming soon. So a good place to start is just reading them. You'll learn a lot from that. The US guidelines are also, they are very similar to the NAPA guidelines, and sometimes one will explain things better than the other, so it's a good place to get more information. The Canadian Society of Hospital Pharmacists have guidelines for pharmacies for both sterile and non-sterile compounding, which are a good source of information, a little more detail. CSHP has some webinars that they've done for sterile compounding, if you're a member, that are available. And in a couple weeks, they're starting some webinars around non-sterile compounding. And some of these others are magazines or other organizations that are more commercially based but might be helpful. So one is Pharmacy Advisor, has lots of CEs and webinars. Critical Point, if you know who Eric Castango is, he was the chair of the USP 797 committee. He has a company that has a lot of information and resources that are either free or you can purchase. Pharmacy Practice and Purchasing magazine is free. You can sign up for a little prescription, a lot of really practical information there. There's gap analysis tools available online for free. One is the USP 797 compliance study, but it helps you systematically go through your practice and identify gaps for improvement. And you can also, if you just start looking online, you can purchase or sometimes borrow, just talk to people and get sample policies or procedures to kind of get you started. So hopefully that was a bit of a whirlwind tour of compounding.